So good evening once again, and welcome to our Fireside chat for this evening. It's going to be a 176th chat. And today we are continuing with our kidney supportive care webinar series. This will be the 8th one. My name is Dr. Yuri Okech, and I'll actually be co-moderating this session together with Erin Das, who is kidney supportive care lead, PHM, and also a palliative care specialist who's leading the teams in different spheres. So the topic for this evening will be on kidney supportive care. The time has come. And our guest speaker for this evening will be Dr. Vivekanand Jha. And he's a professor and executive director at the George Institute for Global Health, India. And he's the chair of Global Kidney Health, Faculty of Medicine at the Imperial College of London, and the past president of the International Society of Nephrology. Professor Jha has a wide-ranging research interests, including understanding the health and societal impact of kidney disease around the world, and development of affordable, scalable, and sustainable primary and secondary prevention tools. He has worked with many organizations, including WHO, to develop clinical practice guidelines and advocacy papers. He has lectured extensively around the world and is a prolific writer and editor. I'm also happy to see, I think I was looking at his bio and I can see he's a conjoint professor of medicine at University of New South Wales, Sydney, where I was actually a student some time back. So I'm an alumni of UNSW, and it's good to see Professor Jha in this forum, as much as I'm far away from Australia. So welcome, Professor Jha. Over to you.
Thank you very much, Yuri, and good to learn of the UNSW connection. And thanks once again to Lloyd for inviting me to join the Africa Health Network once again and have the opportunity to speak with you. It's really great to renew some of the friendships that we have had over the course of the years, and hope to see you soon in some meeting or the other, hopefully in the World Congress of Nephrology, which is going to take place in New Delhi in February 2025. And I hope that we will have a large contingent from Africa. So as Yuri sort of explained, the job that I have been given is to talk about kidney supportive care, right? Or rather the supportive care in nephrology from the perspective of a lower middle income country setting, where this is not really thought of something that is in the immediate front of mind of nephrologists. But I hope to be able to make the case that we should continue to think about it and in fact devote more of our time on this. So I represent three organizations, as you can see on this slide: the George Institute for Global Health, which is my primary affiliation, and the Imperial College London on the right side here on the slide, where I also work, and of course the International Society of Nephrology, which is one of my greatest privileges in life to have been a president of. So let me start by sharing with you a couple of case descriptions to make the point of the kidney supportive care. So the first case that I'm going to describe to you is a 76-year-old white female with long-standing diabetes, hypertension, heart failure, has been on dialysis for the last 6 years in the United States. She has had aortic aneurysm, repair surgery, and hysterectomy while on dialysis. Over the last 1 year, she has had acute myocardial infarction and had 3 stents and a cardiovascular defibrillator placed. Her current ejection fraction is between 10 and 15%. She develops frequent intradialytic hypotension and has a low serum albumin. She remains constantly exhausted, weak, and depressed. She gets chest pain regularly and becomes breathless, walking from room to room and going to the toilet. However, her family is committed to not letting her go. This is a frequent situation that you encounter in several Western countries. And this case really illustrates the point that kidney patients are complex. And here is our data that were collected by Dr. Cello Tonelli, who is the current president-elect of the International Society of Nephrology. And he really looked at the number of medications that are prescribed by various specialists and the number of comorbidities that are encountered by various specialists in their practice. And here you can see in both the number of prescribed medicines and the number of comorbidities, nephrologists are top of the list here. You can see the very top. So I was really making the point that if you look at this slide, you will see that the number of prescribed medications and the number of comorbidities are the largest in the category of patients that are seen by nephrologists, which is in the top bar in both of these, the first and second set of figures, right? Okay, so just making the point that end-stage kidney failure, which this patient exemplified, carries a high symptom burden. The median number of symptoms in hemodialysis patients is 9. Over half of the patients constantly complain of pain, and the other common symptoms include fatigue, insomnia, itching, neuropathic syndromes, poor spirits, nausea, vomiting, etc., which I'm sure you're all familiar with being nephrologists. End-stage kidney failure is also associated with impaired health-related quality of life and high prevalence of depression. And indeed, the survival of dialysis is worse than that of many cancers. So here you can see this 5-year relative survival of patients on dialysis. And you can see that the number of patients with various other cancers that are above the bar that is representing dialysis actually have greater survival than actually dialysis. Of course, there are certain types of cancer and certain other chronic diseases also, like heart failure, which have lower survival than dialysis, but dialysis really has a pretty bad survival. But still, in the practice of supportive care is so very prevalent in the oncology field, but we don't think about it as well in nephrology field. These are the typical trajectories of illness, and you can have various types of diseases with disease trajectories. For example, here is a trajectory of disease of typical patient with colon cancer who might be treated and will do reasonably well. He or she might be functioning well for several years. And when the disease comes or the disease recurs, they go down very fast. Whereas people who have chronic conditions like heart failure, COPD, and end-stage kidney failure, they show a constantly decreasing functional ability with acute dips from time to time, as we are very familiar with in dialysis. On the other hand, you have other categories of patients, such as those with frailty and dementia, who start with at a very low functional ability, and they continue to show reasonably rapid decline. So that is something for us to just keep in mind while we talk about the second case, which comes from a completely different socioeconomic background. So in contrast to the US, we now move to India, which is the country that I come from. And this case too is a 46-year-old uninsured Indian farmer who has been unwell for a couple of weeks, is brought to a hospital which is more than 150 kilometers away with acute breathlessness, and is found to have end-stage kidney failure. A temporary dialysis catheter is placed and he started on hemodialysis. His family borrows money and sells his assets, which include house and cattle, to continue dialysis. His treating team advises him to get a transplantation, but a compatible blood group donor can't be found. Eventually, the dialysis frequency is reduced to as per need, and he's become over time malnourished, edematous, anorexic, and is unable to take care of himself. The family at this point is desperate to find ways to continue treatment. I'm pretty sure that many of you in Africa relate to this kind of situation, and I'm not surprised if many of you see these kind of patients on a daily basis in your practice. What this takes me is to this systematic review that we conducted several years ago, which talks about the worst kept secret in global nephrology, and our data showed that between 7 and 10 million patients need end-stage kidney failure treatment every year, but only about 2.5 million are able to receive it, and everyone else actually dies. And again, this is something that you and I perhaps know very well. So where are these patients who are dying on a regular basis? And these are the patients who live in low-income countries and lower middle-income countries. So just about 7% of all people with kidney failure around the world are in low and lower middle-income countries, which houses more than 70% of the world population. So you can see the unjust distribution of dialysis population around the world. And what I'm going to do is also to share with you the story of this one patient by the name of Baby in India. Let me just first of all try to determine whether you
नींद बहुत आती है, खाना नहीं खा सकती हूँ, उल्टियां आती है। उम्र जी मेरी 38 साल है और मतलब डॉक्टर ने मैं दिखाने गई, पहले मेरे बीपी आई हो या फिर मेरी किडनियां खराब भी हो गई थी जी, ठीक है। और फिर मैं बिल्डिंग शुरू हो गई थी जी, फिर डायलिसिस के लिए भी। नींद बहुत आती है मतलब, ठीक है। और फिर मैं डायलिसिस के लिए भी। डॉक्टर ने जी मेरे को 3 डायलिसिस के लिए बोला है, मैं एक ही डायलिसिस ले पाती हूँ, पैसे कारण भी पैसे का जुगाड़ नहीं। बच्चों पर जी पढ़ाई नहीं हो पाई है, लड़की पढ़ने से घर बैठी हुई है, तो इस करके जी घर के खर्चे नहीं चल पा रहे बिल्कुल भी। मेरे डायलिसिस पे लग जाता है सारा पैसा। मेरे को डायलिसिस फ्री हो जाएगी जी, मेरे को बहुत ही फायदा है, बहुत पैसा लगता है जी। भी मैं ठीक हो जाऊं, अपने बच्चों में सही रहूं, कौन नहीं चाहता भी अपने बच्चों में सही रहे, सब चाहते हैं।
so thanks for that. I'm pretty sure that you're familiar with these kind of situations because we know that from a systematic review that was conducted by a number of leaders of nephrology in Africa, that a very, very small proportion of people who start dialysis in sub-Saharan Africa are able to continue dialysis. And these authors concluded that most patients with end-stage kidney failure starting dialysis in sub-Saharan Africa discontinue treatment and die. What is the main reason? The main reason is that the treatment for end-stage kidney failure is expensive. In low and middle-income countries, the number of people who experience catastrophic healthcare expenditure as a result of kidney disease treatment, which is dialysis, is the greatest of any other chronic disease type. Even in high-income countries, treatment of end-stage kidney failure consumes about 3% of healthcare budget, but the number of people who consume this budget are almost 1/100th of the proportion of the healthcare budget spending. Now, as a result of this, a number of countries which have publicly funded healthcare are thinking increasingly about the opportunity to utilize conservative care more and more efficiently. So in countries like Australia and Canada, for every patient who starts dialysis, there is another patient who has comparable kidney function but does not start dialysis. Amongst the patients who withdraw from dialysis in the Western countries, chronic fatigue or failure to thrive after acute medical complication is the most common indication. Let's come back to what we hear when we talk to our nephrologist colleagues on a daily basis. We all fear that watching patients deteriorate and die, we think that it's an inevitable part of our work. And as a result of that, what has happened is that we are often haunted by the assumption that death is a failure and that we can't really give up and that we must do all that we can to keep these people alive. We often encounter uncertainties in determining prognosis of our patients, And we are often not sure when we should say enough is enough. And we worry that patients will misunderstand and they will interpret it as lack of compassion on the part of the nephrologists. But then really that is not the case. And the International Society of Nephrology has come up with this framework for setting up dialysis, and really it has provided this model to support decision makers in promoting kidney health and implementing integrated kidney care. And as you can see, the greatest primacy is given to prevention, right? Because prevention obviously is likely to give the maximum return for the investment that is made by the healthcare system. But before we start putting patients on dialysis, we must make sure that conservative kidney management, which is shown here alongside peritoneal dialysis or hemodialysis, is considered as an integral part of integrated kidney care program. So supportive care or palliative care, what is it? That often comes across as an important question. So the World Health Organization has defined as palliative care being an approach that improves the quality of life of patients, not only the patients, but also their families who are facing the problem associated with life-threatening illness, through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other physical, psychosocial, and spiritual problems. So please note the wide-ranging definition that it includes not only the patients, but also their families, and that it not only thinks of alleviating the physical symptoms, but also the psychosocial symptoms and spiritual problems. So then you will ask the question, why should we talk about palliative care or supportive care? Now there is sufficient data that tells us that this approach improves outcomes by proactively addressing burden of people with advanced kidney disease, and that accepting palliative care does not compel patients to decline treatment such as dialysis. So this is often, there is an understanding that palliative care and dialysis are dichotomous treatment, that anyone who accepts palliative care will just have no place in a dialysis unit, but that is not the case. And of course, the final point that I would like to make is that good quality kidney palliative care delivery requires all kidney care professionals to have basic palliative care skills. Now, this is a conceptual diagram that was developed by Dr. Sarah Davison from Canada and her colleagues. And Dr. Sarah Davison is a leader in the field of palliative care. She developed this as a part of the work that was done to develop the integrated end-stage kidney failure treatment strategy by the International Society of Nephrology. So here you can see that the green section here, the green diamond that you see, or the green hexagon that you see, represents the area or the component of the treatment that is that really represents kidney supportive care or kidney palliative care. So we may have two different types of situations, as was exemplified by the two patients that I presented to you. The first patient presents in a situation where kidney replacement therapy is freely available, and patients have access to dialysis or transplantation. So if someone is able to undergo transplantation, obviously that is the best treatment for them, and there the role of kidney supportive care is very little. Whereas if a patient is started on dialysis, whether it is hemo or peritoneal dialysis, the component of kidney supportive care is actually much greater. And eventually, over a period of time, hemodialysis or peritoneal dialysis will fail or transplant will fail. And these patients will enter a phase in which majority of their treatment consists of conservative kidney management. On the other hand, in the geographies that you and I work in, kidney replacement therapy is often unavailable. And therefore, what we have are two major groups of patients. One is a group of patients with undiagnosed kidney failure and a group of patients with untreated kidney failure. And there is very little we can do for them. But for people who are identified to have kidney failure, it is our responsibility not to abandon them completely because they just can't access dialysis. But it is quite possible that we can provide them with humane care through conservative kidney management or supportive kidney care. But there are a number of dilemmas in which that we face in determining end-of-life care for dialysis patients. So these consist of two sets of dilemmas. One is that there are a number of limitations of withdrawal practices. We are often trapped in a cycle of over-dialysis. And our decisions are often driven by our personal beliefs and choices. And often patients also really don't understand the kind of treatment that they're getting and the limitations of what that treatment can achieve. On the other hand, there is a knowledge barrier to better end-of-life care as well. There is no realistic awareness of prognosis. There is a lack of awareness on the role of other colleagues, what they are doing. And we often face role conflicts, and no one knows whose responsibility is what. Even if a patient is started on dialysis in a resource abundant setting, there are a number of barriers to dialysis withdrawal. And these barriers can be grouped under two factors. The first group of factors are patient and family factors, which include lack of awareness of an option. The patients often don't know that they actually have an option. Many people consider withdrawal as being a sin or as a kind of giving up, and that they have fear related to others' acceptance of their decision. Many people are really unrealistic about their medical condition and prognosis, and they often feel that continuing dialysis will perhaps result in some sort of miracle. Some patients may lack decision-making capacity, or there is a fear of outcome on remaining loved ones, or there is a perceived family need that if this individual dies, what will happen to the rest of the family? And that the fear of the withdrawal might signify a lack of hope. On the other hand, a number of healthcare provider factors also come into play. Healthcare providers often are unable to appreciate estimating the uncertainty about the prognosis of a specific patient. They are not able to understand patients' wishes, and sometimes they also may have unrealistic expectations about prognosis. They may maybe unrealistically feel that the patient will be able to do much better than the patient can actually do. The healthcare providers may be unable or may be unwilling to communicate the option of withdrawal from dialysis. And sometimes some of the healthcare providers may actually have an ethical opposition to withdrawal. And last but not the least, in many healthcare systems, which are dominated by private providers, the health system also pushes to continue dialysis because the longer the dialysis is continued, the more money the healthcare system stands to make. So then in this situation, what are the potential triggers that should allow us to identify patients for whom withdrawal of dialysis and kidney palliative care should be considered? So and we'll come to that in a minute, that the physician answer to no, I would not be surprised, to the surprise question, and we'll come to the surprise question in a minute. And sometimes when poor prognosis is predicted based on patient-specific estimates of prognosis using some validated tools, when you're seeing that the patient is increasingly getting hospitalized, the patient is not thriving well, and is experiencing loss of function, and or that sometimes there may be a non-renal terminal illness that is diagnosed, or that the patient has lost the drive to continue, or they have severe unremitting illness. So here is a surprise question. Maybe we should ask ourselves for each patient whether we will be surprised if this patient died in the next year. When the answer to that question is that no, I will not be surprised, actually the survival is shown to be much lower, as you can see in the graph on the left here. So what it means is, and this is actually better than the survival which is predicted by comorbidity scores. So even the physician intuition is quite helpful in making this distinction. So having discussed those points, let's now look at the components of comprehensive conservative care. So the comprehensive conservative care is the planned, holistic, patient-centered care for patients with end-stage kidney failure that will include interventions to delay progression of kidney disease and minimize risk of adverse events or complication. Because even if the patient has has entered stage 5, which means EGFR less than 15, they may still have many months left in them if we are able to even preserve the little bit of kidney function that is left. We should also be able to understand the principles of shared decision making. We should know how to manage symptoms actively. We should be able to communicate appropriately, including advanced care planning and psychological support. We should be able to deal with the issues of social and family support and take care of the cultural and spiritual domains of care. And the last point to be made is that comprehensive conservative care does not include dialysis. Although patients may sometimes choose to go back on dialysis, but comprehensive conservative care by itself does not include dialysis. Now, let's come back to what is called a choice-restricted pathway. And what is a choice-restricted pathway? This is the pathway when a patient does not really have the choice to go on dialysis, okay? So you in your clinic might identify a patient as one who requires kidney replacement therapy. The first question you will ask is there a reversible component? Is there an acute kidney disease? If the answer to that is yes, then we all go ahead and treat that reversible component. And sometimes if there is acute kidney disease, the patient will recover. Or if the patient has acute kidney disease on top of a chronic kidney disease, then of course there will be some recovery, but then we'll need to continue to follow up this patient on a regular basis. If there is no acute reversible component, then the first question we'll ask is if the patient is a candidate for kidney replacement therapy. If the answer to that is yes, the first thing we want to, in your and my setting, is to ask if the kidney replacement therapy is affordable for the patient. If the answer to that is yes, then of course we will determine the mode of kidney replacement therapy. We will align and educate. If the answer to that is that no, this patient is not going to be able to afford kidney replacement therapy, then first we should ask, is there access to subsidized government dialysis or NGO that will provide dialysis? And again, if the answer to that is no, then we have no choice but to consider this patient for conservative kidney management. Okay, so that's really which is something which is important. We need to be mindful of these 7 C's, which is part of the gold standard framework. And they, starting from the top, is symptom control. So control is the C: coordination, continued learning, continuity, care in dying phase, carer support, and communication. So these are the important ones. So then let's move now to how to operationalize these principles. How do we begin to provide supportive care to kidney patients? So the first thing that we need to learn is patient-centered communication by active listening, responding to emotion, and gaining patient perspective. After that, we need to elicit goals of care by providing the patient with prognostic information, eliciting their values to inform treatment decisions, and then go on to determine the practices for basic symptom management. And we need to take into account both physical symptoms and psychological symptoms here. So for symptom control, we need to first of all assess, rule out reversible factors, consider non-pharmacological interventions, because they may become unrealistic later. We don't often appreciate it, but there is a lot of value in encouraging patients to do exercise. The use of drugs should be considered only as the last option. Aim of symptom control here is to ameliorate symptoms that impair quality of life. And finally, we must remember that patients often underreport symptoms. So we should use validated symptom measurement tools. And there are a number of validated tools that are available, and I will give you resources for that later on. In terms of managing progression and metabolic complications in patients with chronic kidney disease, we have to realize that at this time, we don't need to be very strict with blood pressure targets. We can discontinue a number of drugs such as statins, uric acid lowering agents, and we don't have to necessarily manage calcium and phosphorus very aggressively, but we should prioritize nutrition and quality of life. We should use diuretics and sodium restriction for volume control, iron and ESAs to manage anemia, soda bicarb for managing acidosis, And of course, we should manage potassium by dietary restrictions. And now there are a number of new drugs that might help, but unfortunately, they are expensive and they are not available in many countries, including yours as well as mine. One point that I would like to emphasize is please do not focus on biochemistry. Do not repeatedly get multiple investigations and try to use the numbers to guide your treatment, okay? There are a number of symptoms that you all are aware of, and I won't spend a lot of time, and I'm happy to share the slides with you so that you can actually look at it in your spare time on how to manage conditions like restless leg syndrome, pruritus, cirrhosis, nausea, vomiting, pain, and other symptoms like breathlessness, pain, etc. And I will also draw your attention to this publication by Sarah Davison in C. Jathan in 2019, which gives specific algorithms for breathlessness, pain, etc. Sometimes actually drowsiness may not be bad. You may prefer your patients to be drowsy because they will feel less pain. And they should all receive nursing care as needed. Now, the last bit is that how do we implement this? How do we change our practice to include supportive care in our practice? So what we need to do if we are serious in implementing this in our practice is to create a diverse stakeholder group. You should go out and look at your local needs and the resources that are available in your local geography. Then you should build a team, and this team should ideally consist of a nephrologist, a nurse, a social worker, a psychologist, a spiritual care provider, and a dietitian. I'm aware that not all of these expertise may be available to all of you. They are certainly not available to me in many instances. And so therefore, we need to develop these skills, some of these skills in other members of the team. After that, we should define the organizational vision for our kidney palliative care treatment. And here is a tip. You can do that well by developing partnerships with other services or hospices. As I said before, there are certain specialties such as oncology, etc., that are very experienced in providing kidney palliative care services. And lastly, if you want to grow and innovate, you must develop an evaluation plan and also a plan for continuous education. Processes required to establish conservative kidney care, kidney management programs can be divided into 5 buckets. We need to have appropriate policies that support the provision of kidney palliative care or kidney supportive care. We need to educate all the healthcare provider teams on kidney supportive care. We need to make sure that all the essential medicines that are required for taking care of these individuals are available, which include painkillers, sometimes opioids, etc. And we should have a clear plan for implementing these solutions. All of this must be underpinned by academics and research. So there are 2 types of kidney palliative care, and it depends on how ambitious you are on what kind of kidney palliative care service you want to establish. So there can be a primary kidney palliative care service, which simply manages basic symptoms. It diagnoses and starts initial depression and anxiety treatment, and is actually trained in basic components of serious illness communication, like prognostic understanding, initiating advanced care planning, and address basic goals of care. But if you are really ambitious and you want to become even better, then you should aim to develop specialized palliative care services. And in specialized palliative care services, it can be actually a referral center that will address refractory symptoms, manage complex mental health problems, which include sometimes existential distress. And it might be also trained in complex serious illness communication by addressing complex goals of care and managing sometimes conflict resolution regarding goals of care. The conflict resolution can be between different groups. For example, it can be between patient families, it can be between patients and even treating teams. For example, doctors may feel differently compared to the patients. And sometimes even within the different members of a multidisciplinary team, there might be conflict. If you don't have a lot of resources, I would suggest you consider developing this hub and spoke model to support competency-based care capacity in conservative kidney management. And again, I will not go into the details of the various components that this figure describes, But I will draw your attention to this paper by Sarah Davison, which was published in Kidney International in the January month of this year, which is part of the International Society of Nephrology framework for comprehensive end-stage kidney failure care, that gives you a very good description of how this hub and spoke model works. So therefore, in conclusion, my dear friends, I would like to hope I have been able to leave this with you, that conservative, supportive, or palliative care is an integral part of chronic kidney disease and stage kidney disease continuum of care. All of us at kidney care professionals need to develop kidney palliative care skills. Sometimes we need to develop specialized kidney palliative care centers, and they need to be developed on lines of those for patients with terminal cancer. In fact, providing this kind of care improves our ability to provide really patient-centered care to those with kidney disease. Kidney palliative care, more than anything else for health systems, it rationalizes cost of care and provides comfort to patients and their families. Now, for us, it is time, for you in Sub-Saharan Africa, for me here in India, it's time for us to start the dialogue that enough is enough when we feel it is appropriate. But for that to happen, we need to invest a lot in capacity building, resource development, ensuring availability of appropriate medications, and also enabling structural frameworks which currently limit the supportive care needs of low middle income countries. With that, I'll come to the end of my presentation, but I will not, I would be failing in my duty if I don't draw your attention to the World Congress of Nephrology, which is scheduled to be held in February 2025 from 6 to 9 in my city, which is New Delhi, India. And I would really very much like to see as many of you come to this Congress as possible. I would like to draw your attention to the fact that the abstract submission deadline has now been extended to 14 September. So you have another 9 days to submit your abstracts. So please go ahead and submit if you think that you have an abstract in you, but somehow have not been able to find the time, or you thought that the deadline had passed. The deadline has been extended by about 10 days or so. And also that there is an early bird registration deadline on 6 November 2024. So with that, I come to the end of my presentation, and I'm happy to take any questions.
Thank you so much, Professor, for a really, really interesting discussion and lots of points. There's been a lot of questions that have been coming in. So I will direct them at you, and yeah, hopefully we'll have some more questions. So an interesting one has come through related to a patient and his faith and his religion. So it says here, we recently had a patient of Shia Islamic faith whose family chose to continue with hemodialysis. Despite our advice, the family chose to continue as the religion does not allow a do not resuscitate, or DNR. How do cultural and religious beliefs influence these end-of-life care decisions for patients? And how can we as clinicians provide culturally sensitive care?
Yeah, that's a very important question and somewhat difficult to respond to, because even though this individual expressed this kind of desire, I don't think this is a universally held view in even in this this sect of Islam, right? Because there are many countries which are Shia Islamic countries that have kidney supportive care programs. So I'm not sure, but of course we have to respect the views of the patient and their families. But what we might want to do is to encourage them to get in touch with their religious leaders and to find out alternative opinions. Often alternative opinions are available, and we can respectfully draw their attention to them. In the end, it is a shared decision-making process. We can't make the decision for the patients or their families. And the patients, of course, as you said, take recourse to a number of sources of information. There are certain sources of information they trust better than the others, and we have to respect their wishes at that particular point of time. But of course, so that is why it is called shared decision making. We can't impose our wishes on the patients, but we should do all that we can to point them in the direction of as many sources of information as possible.
Yeah, I really like your answer, thinking of a holistic approach. Sometimes we can be very black and white in these kinds of conversations with families and patients, and us as clinicians often are not. So we do need to bring others in that they will trust and help them along with that decision making. An interesting question. So what are some indicators, or what are some reasons that we would consider transitioning to supportive care? And how can we communicate this with patients and caregivers?
Yeah, so I had a slide, and maybe I can show you once again as to when do we start considering, the need for supportive care. So these are a few situations where we should start seriously considering supportive care. So if a patient is on dialysis, or if a patient has come to you in your clinic, the first question is what we call the surprise question. Is that physician, when they look at the patient, they ask themselves the question, will I be surprised if this patient dies in the next 6 months or 1 year? And if the answer is no, I would not be surprised, then we should consider supportive care for such patients. Or if we use some kind of validated tools, and that tool tells us that this patient has a poor prognosis, then again, we should consider supportive care for that patient. Or if we have seen that in the last 6 months, 1 year, the patient is increasingly coming to the hospital, the patient is he or she fails to thrive, there is increasing loss of function. Or what might happen is that there is, another non-renal terminal illness may be diagnosed, like a cancer or heart failure, etc. And finally, sometimes what happens is that patients themselves lose personal drive to continue, or they may develop a severe or unrelenting depression. So those are the situations when we should consider offering supportive care to our patients.
Yeah, we've been trying to also identify in our clinics in Kenya how to kind of triage the patients that could benefit from a supportive care visit, a supportive care kind of care plan. And we also have had to do something very similar. We can share it with the group, but there's about 8 different criteria that we are encouraging our nurses and our clinical officers to actually begin to triage which patients need supportive care first, so that our nurses that are trained in palliative care, who've done a higher diploma in palliative care, are able to see those patients first. And I would agree, hospitalization, patients with multiple comorbidities, anyone with another advanced disease, patients who have severe untreated emotional concerns. Yeah, so we can actually share that with the group. It's something that we've been working on and testing and seems to be effective. Our team in Kenya have been identifying, though, that nearly all of the patients in the clinics that we are seeing could benefit. So I think this is the balance, right? How do we identify of 50 patients, the top 20 that need it? It can be a bit difficult.
That's a very important point, that almost all patients can benefit from palliative care or supportive care, so this is very important. So no matter which state, even if a patient is on dialysis, what we call supportive care is something that is no longer restricted to patients, that they have to be taken off dialysis, only then can be offered supportive care. So this is a slide that I didn't show you. So this is, the evolution of how we think about palliative care. So in the past, we used to think that we often have a phase that the patient receives active treatment and then abruptly transitions to palliative care and then will eventually die. But then that has now changed. So now we have a phase in which we have a treatment which has the intention of either curing or prolonging life, certainly, which is dialysis. But at the same time, we have a palliative or comfort intent also alongside, right? And the scope of the latter increases as the disease advances more and more. And eventually, it will become perhaps the totality of this patient's treatment. And of course, eventually death will ensue. But also the fact is that following the death, there is a period of bereavement which the family will have to go through. So the palliative care or supportive care encompasses the entire range of the lifespan of treatment of such patients.
Mm-hmm. I think it's really important that this is concurrent care. It's not that patients need to choose. When we think of supportive care, we are thinking of a team and providers and approach that is surrounding the patient and family. So I think that's really, really important. An interesting question on the Q&A. I think this goes back to your really moving video that you shared about the woman in India. Does suboptimal once weekly dialysis count as conservative kidney management?
So it is part of conservative kidney management, because you have to, like I said, we have to talk to the patients as a part of our shared decision-making process. We have to establish the goals of care. What is it that the patient is looking for from treatment, right? Some of the patients may want to get the best quality of life that they can from the treatment. We often come across patients who will say that, doctor, I just want to live for 1 year because I want to see my daughter getting married off, or because there is some important life event that I want to make sure that I'm around for, right? And what will it take me to be to live for that long, And that's a matter of negotiation or shared decision making. And sometimes we may agree that yes, you don't have to necessarily receive it 3 times a week or twice a week dialysis, but maybe once a week dialysis will pull you through the next 6 months or something like that. So yes, I agree that and alongside, of course, if the once a week dialysis is inadequate in terms of symptom relief, the patient will have symptoms, and so we should continue to provide additional management to support to take care of the symptoms of such patients.
I think in that situation, it sounded like the once a week wasn't necessarily a choice that they made. It sounded like it was the reality due to the economic situation, which again is often what we're facing. Thankfully, in Kenya, most of our patients are able to access dialysis through our National Health Insurance Fund. But yet, we are also working in other places where it's not the case.
Yeah, and sometimes you can make that decision electively as a part of what we call the escalating care, that we don't want to necessarily start with 3 times a week dialysis. If the patient has reasonable residual kidney function, then we start with less frequent dialysis, either once a week or twice a week dialysis. And then we may transition to more frequent dialysis as needed.
Yeah, really, really good to have these discussions. There's one more question as we come up to the end of our session tonight, and then I'll pass it back to Dr. Yuri. But how can we as healthcare teams better integrate mental health support for our patients who have chronic kidney failure, and as well as their families? So in your experience, how can we as frontline providers offer that support?
Yeah, this is a good one. And this goes
Golden
back
question.
Yeah, this is a golden question indeed. And this goes back to, what does nephrology mean to all of us? So now it takes me back to more than 35 years when I was in the process of choosing a specialty career, right? And one of the important reasons I chose nephrology is that it was as close to internal medicine as possible. And so a nephrologist has to be familiar with managing multiple problems. As I showed in my slide, that nephrology patients have the largest number of symptoms. They have the highest prevalence of anxiety, depression, mental health issues, etc. So as a nephrologist, we do need to become somewhat experienced, at least in managing basic anxiety, basic depression, etc. Right? Of course, we will not be able to manage all patients, and we should be prepared to accept when our line of management is not appropriate for a given individual, in which case we'll have to send them or refer them to a specialist psychiatrist, etc. But as nephrologists, we should be familiar with at least with basic concepts of managing patients with these mental health issues.
I think one of the things that I'm learning more as I take care of patients with kidney failure is the trust that our patients have with nephrologists is very strong. You, as a specialist, the patients and the families really do trust you. And I think one of the challenges I would put out to everyone on the panel, but also beyond the panel, all of our participants tonight, is we need buy-in that supportive care works. So if you as a nephrologist can vouch for supportive care, for symptom management, for patients accessing more mental health support, I think that, yeah, we will be able to support you as well in some of your conversations that you have with patients directly. And yeah, hopefully we can continue to provide really good, high quality of care services to our patients. I think Carlos has a really specific question. Dr. Yuri, there's a question here. In your opinion, even when patients don't present with some of the criteria for supportive or palliative care, but the treatment doesn't cover more than 18 sessions?
No, it's in Rwanda. Rwanda will have
Rwanda.
Yeah, in
Okay.
Rwanda. And the patients, the patient, the outcome is very good, but the government and the situation says, oh, you just stay in 18 sections. How can you prepare the family and the patients to make this,
18 sessions of dialysis, full stop.
Yeah, so these are health system related issues, and we all have to be aware of the health system related issues in the health systems in which we work, and we have to develop solutions. So, it's not uncommon that health systems support a particular treatment, in this case dialysis, for a finite duration, a finite number, and we will have to have a plan. And so this is the area where we need to have a very transparent, clear way of communicating this with the patient, so that the expectations are not unrealistic in this situation, and they know what they are in for. And because we don't want to abandon the patient, but to also present the patient with a plan. Here is our plan for what we will offer to you once your a number of treatments that are provided through the health system comes to.
Lots of questions coming in at the end. I'm going to pass it over to Dr. Yuri. I will do my best to answer some of these in the chat, but over to you, Dr. Yuri, as we come to a close. Thank you, Professor. Thank you so much.
Thank you, Erin. And I think some of the questions are been addressed to Erin, so I'm sure she'll be able to reach out to participant by the name Janet, and also touch base and see how they can work in pushing the agenda of kidney supportive care. And to me, I just want to say thank you to Professor Jha. I think I do agree. This is a very hot topic, and we agree that it's time for kidney supportive care. The time has come for it. And you have really made it quite simple. And we also understand how do we consider patients that might require this, and very grateful for the talk. On my side, I just want to convey. Yes, Professor.
No, I was just going to say that, at the end, we are all nephrologists.
Thank you very much.
We want to provide active care, and we think dialysis is active care. But my plea to all of you would be to not set up dialysis services and forget completely about palliative care. Because no matter whether the patient is receiving dialysis or is unable to receive dialysis because of some reason, every single patient will require palliative care. Believe me, So we are not doing justice to our patients if we are completely forgetting supportive care or palliative care.
Agreed, 100%. And I think with the team that we are now building at Africa Healthcare Network, led by Erin, we'll be able to push this agenda going forward.
Completely agree. I mean, I think every single patient needs palliative care, and we hope that we will be able to build that into our system to make that an extremely wonderful session and cover the whole of the important aspects of palliative care. We would actually like to review our whole program maybe once in 6 months to see if we have got a right direction or if there's something new that we can actually do from what we are doing. And so make an impact in what we deliver to our patients. I'm extremely grateful for this session. I know you're very busy and it's now really late as well and standing up this time. And you've helped us a lot in the last sessions as well. Now, sir, third time that you've come despite your busy schedules. Extremely grateful. Also, we would like your slides. I would like to have your slides, please, because I would send it across the board, because I think the awareness of this concept of kidney supportive care should actually go across the communities and to show that this is also available as a modality of care today in nephrology. Thank you so much, and we hope that we will definitely be there in Delhi for the conference, and hope to meet you there. Thank you so much. Thank you very, very much. Thanks, Vivek.
Thanks, Lloyd. Thanks, everybody.